good evening, morning, because we are passing the morning now, and I want you all to be enjoyed with this PEDIA Egypt Congress, which is illuminating our science. And thanks for the organization. Thanks for Dr. Wael Bahbah, Dr. Mohammed Zannoun for inviting us to share with you this illuminating Congress. I'm happy to introduce Professor Fahd Al-Suhaimi, King Saud University, and he will talk to us with a special talk, nusinersen in spinal molecular atrophy, respiratory outcome at tertiary care centers.
السلام عليكم صباح الخير جميعا بسم الله والصلاة والسلام على المرسلين. I would like to thank the organizing committee for the invitation, and special thanks to Professor Wael and Professor Mohammed for the generous organization and invitation. So I'm Dr. Fahd Al-Suhaimi. I'm a pediatric ICU consultant. I'm also an assistant professor in pediatric at King Saud University in Riyadh, and I would like to have this presentation about the care of patient with spinal muscular atrophy and its outcome in the PICU through a national experience that we had in Saudi Arabia. So this is okay. So first of all, I don't have any conflict of interest or financial interest in any of the companies who are caring for the patient with spinal muscular atrophy. These are the outlines that I will go through during my presentation. I will go through a brief introduction about spinal muscular atrophy, and then I will go through what are the respiratory attitude support toward patients with SMA in the PICU. Then we'll go what are the new modalities of treatment for these patients. Then special talk about the Spinraza and its outcome in Saudi Arabia. So spinal muscular atrophy, it's a pediatric neuromuscular disease. It's autosomal recessive, and it's considered the most common cause of infantile death, as a genetic cause of infantile death. And it's characterized by degeneration of the motor neuron at the spinal cord and the motor nuclei also. Do you want to put this one? It's easier. Can you hear me well this way? كذا أحسن? Okay. So spinal muscular atrophy is characterized by the degeneration of the motor neuron at the spinal cord and the motor nuclei at the brainstem too. The incidence rate is estimated to be 4 to 10 per 100,000. And North America and also in some of the countries such as Australia. And the cognition in these patients is unaffected. So this is what happens. There's a mutation in spinal and SMN1 gene which lead to alteration of the splicing as SMN2, which would lead to the loss of the motor neuron and ultimately muscle weakness and death and atrophy of these muscles. Unfortunately, we don't have any local registry in Saudi Arabia, how many patients of SMA we have. But this is a pilot study that was conducted a few years back. It was estimated the SMA carrier around 5%, as you can see on this abstract. And they related this to the high level of consanguinity. Other nations, they have reported SMA carrier to be 1 to 2%. So we have a higher level of SMA carrier in Saudi Arabia. So there would be a deletion of the SMN1 gene. This would lead to lowering the level of production of survival motor neuron protein, which is responsible, okay, to produce the mRNA and the motor neuron and inhibit the degeneration and apoptosis at the motor neuron. And there is a wide spectrum of classification of SMA, ranging from type 0 to type 1. The most common types are type 0 and type 1, and these are the most severe forms. As you can see in this table here, their life expectancy does not bypass 2 years old in this category of patients. Then we have the type 2 and 3, which are milder form, and the least severe form is type 4 in these patients. Regarding the SMA management, it's a multidisciplinary management where it involves the neurologists, the rehabilitation physicians, the dietitian, and the acute care, along with the respirologist. So we conducted this study, okay, just to see how would the intensivist manage these patients in the pediatric ICU. Are they aligned with the international consensus guideline for management of SMA patients? So it was a cross-sectional study that we conducted, and we included almost 40 physicians pediatric ICU consultants who are working, majority of them are working in tertiary governmental hospitals. So 66% of them were unaware of the international guidelines for management of spinal muscular atrophy. Then when we asked them regarding several statements, for example, the first statement, in acute exacerbation, would you intubate these patients or not? So as you can see in the figure here, majority of, almost 50% of them, they disagreed. They wouldn't intubate them at the acute exacerbation phase. And the second statement, shall we propose for these patients chronic home ventilation? And again, 50%, almost 50%, they were against presenting them with the chronic home ventilation support. Then when we asked them, shall we offer tracheostomy for these patients? Majority of them said no, we wouldn't offer them tracheostomy. Then when we asked them, would you consider withholding the mechanical ventilation? Would you put them on DNR? 60% of them said, yeah, we would put them in DNR. So we took their statements and we compared it with the international guidelines for SMA patients, the consensus statement that was released. The first one was released in 2007 and the latest was released in 2017. So as you can see, the first statement, if non-invasive ventilation fails, the non-sitters, which are the SMA type 1, may be intubated as acute care management or short-term measure for these patients. So this is against the usual practice for the physicians working in the pediatric ICU. Then the second statement, if non-invasive ventilation was needed during acute illness, home ventilation can be offered for these patients. And again, I will repeat myself here, in non-sitters with frequent respiratory infection, tracheostomy and ventilation can be considered for these patients. And the fourth statement is regarding whether shall we put them on DNR or not. It's mentioned here, with deterioration function, it might be appropriate to shift them to a palliative approach. So this just gave us a proof that we are not aligned with the international consensus guideline for SMA management. So as a conclusion, we said we need to increase the awareness of these guidelines. We need to avoid the variation of treatment among the different healthcare centers. And these are the guidelines which, this is the latest guideline which were released in 2018. This is the first part talking about what are the diagnostic workup should be carried out for these patients, what kind of rehabilitation and nutritional care should be provided for them. Then the second part talks about the pulmonary and acute care for this patient, and even the ethical issue or ethical dilemma that we face it with SMA patient. Then we conducted another study just to check what's the effect of new modalities of treatment on the decision of the physician. Would it alter our decision or not? But at that time, we included more specialties with us, mainly the neurologists who were involved. So again, it was a cross-sectional study. We included almost 160 physicians. Majority of 50% were pediatric neurologists, and the others were from different disciplines. Majority of them were 50% were consultants, and the majority of them working in tertiary governmental hospitals. So as you can see, it's the same principle applies here. 50% of the participants were not aware of the international guideline. And when we asked them regarding are you familiar with the new medication which are released for the SMA patient, nearly 50% were not aware about it, and the other were hesitant about it, and they're not sure about its outcome. Would it improve their outcome or not? And when we ask them, would we reverse the code status for this patient after the appearance of this medication? So again, we have 25%, they said no, they would stick to the DNR decision for SMA patient. So this is just, it was just to guide us what are the gaps that we need to work on in Saudi Arabia in terms of SMA patient management. So there is a wide difference in the clinical experience of the physician who are taking care of SMA patients from different disciplines, and these data demonstrate that we need to carry out more campaigns, more awareness of the new modalities of treatment, and also the international guidelines for management of SMA. I will go briefly through the new modalities of treatment, this brief presentation. So we have the SMN1 and SMN2 who are located on chromosome 5. So if you had any patient with SMA, usually you have a deletion of the SMN1 gene. And the SMN1 and SMN2 are 99% identical, except for the transition of C to T and exon 7, as you can see here. So this is the SMN1 on the left side of the screen, which produce the survival motor neuron protein. So if we had patient with SMA, they wouldn't have the SMN1 gene, it will be deleted. So we are left only with the SMN2 gene. What's going on with SMN2? SMN2, it has a splicing, what we call splicing error. So there will be a skipping of the exon 7, and this would produce an altered protein. So as you can see, majority of the produced protein, it's called truncated or non-functional protein. Only 10% are functional. So it can be a poor backup, or it can replace partially the defect of the survival motor neuron, but we cannot rely on that. That explains why if the patient had more copies of SMN2, they would have a lesser clinical manifestation of the spinal muscular atrophy. And this is appearing here. As you can see, with the increased severity of the decreased severity of the SMA, you will have more number of SMN2 copies, starting from number 3. If you had 3 copies and more, you will have SMA type 2 and more than that. So in the new era of therapy for the SMA, there are 2 approaches. The first approach is the gene therapy, and the second approach, what we call the antisense oligonucleotide. So the investigator they were able to extract a vector from the adenovirus, which carry an encoding DNA to produce a survival motor neuron protein similar to the SMN1 gene. So it would produce a functional SMN protein, and this would help in the survival of the motor neuron. Principal studies on SMA mice showed that there is efficiency of this medication, which led to the normal development of the neuromuscular system and the SMA mice. There was only one study, it was a phase 1 or phase 2 study, which was carried out on 15 patients with SMA type 1, who received only 1 injection of the gene therapy, and the results were amazing, where, as you can see, all the 15 patients were event-free for 20 months, okay, compared to the survival of only 8% in the cohort study, and it led to the improvement of the functional outcome and the motor achievement in these patients, where, as you can see, 11 patients, they were able to sit, and 2 patients were able to walk among the 15 patients. So this is it's a major achievement for this medication. The only obstacle for this medication, which might be an obstacle, it's not released yet, it's not approved by the FDA, is the cost of this drug. It's a single dose drug, and the cost of this medication was estimated to be from $1 to $2 million for 1 injection only. Then the other medication, which we call the Spinraza or the nusinersen, which it works on the SMN2 gene to fix the splicing error. So instead of skipping the exon 7 and producing an untruncated truncated protein, no, it will include the exon 7 in the production of the survival motor neuron protein. So this will lead to the production of a normal survival motor neuron protein. So as you can see here, this is a SMA patient with deleted SMN1, and the Spinraza will work on the SMN2 to fix the splicing error and produce more functional survival motor neuron protein through a technique called antisense oligonucleotide. This is the pipeline discovery for the Spinraza, which started in 2001, and it's the only medication approved by the FDA in 2016. So there are multiple clinical trials that has been started for this medication, starting from November 2011, which created a major achievement for these patients. The major study was the ENDEAR trial, where they included 81 patients in the treatment group and 41 patients in the placebo or the sham control. And this study was interrupted in the middle because of the improvement in the interim analysis. So all the patients in the sham arm were shifted to the treatment group because 50% of the treatment group, they showed improvement, where there was 0 improvement in the sham arm. Then the other study is called the CHERISH trial. It's a phase 3 study too. And this patient was applied for a late onset patient who are symptomatic, and again, it showed a significant improvement in this category of patient. Then the Nurture trial, it's a phase 2 trial, but this trial was done on the pre-symptomatic patients. They included 20 pre-symptomatic patients who are aged 6 weeks or younger, and again, the interim analysis showed significant improvement, so all the patients from that placebo group were shifted to that treatment group. In Saudi Arabia, this medication was introduced in November 2017, and we had several patients who received this medication from different institutions. So we decided to do a retrospective study for this patient and to decide the outcome of these patients from PICU point of view. How many of them they were transferred out of the PICU? How many of them were extubated or weaned from the mechanical ventilation? So we had 21 patients who received the Spinraza over the Kingdom of Saudi Arabia. 9 patients of them only received it within a critical care setting, and only 5 of them they received within a pediatric ICU. The other 4 patients they did not receive standardized care, so we did not include them in our cohort. And these are the 5 cases whom we included in our study. So as you can see here, majority of them, they were dependent already on mechanical ventilation when we introduced this medication. There was an interval of at least 9 months to 28 months between the diagnosis and the introduction of the medication. 4 of these patients, they were not unable to be weaned from the mechanical ventilation, and they were not able to be discharged from the pediatric ICU. The only patient who were able to be weaned from mechanical ventilation and discharged from the PICU is the one who was not already dependent on mechanical ventilation. So, in conclusion, for this small sample size study, that the response to the medication is dependent on the age of the introduction of the medication, what is the disease progression at the initiation of the therapy, and the interval between the diagnosis and the introduction. This needs to be calculated or considered for these patients, but we need to run a further larger studies. So we are conducting now a prospective study just to evaluate the efficiency of Spinraza. This is a working group from Europe who are suggested to have the best therapeutic window for SMA patient is to be given at the beginning, from birth until the initial stage of the spinal muscular atrophy, and this therapeutic window would narrow with the time. So nowadays, this medication has been stopped in Saudi Arabia. Okay, they want to come out with criteria or guidelines to whom this medication should be given because of the high cost of this medication. Because this medication needs to be given at minimum 4 injections, and each injection costs $125,000. So it's heavily costly. So now we are coming up with new criteria and guidelines to give this patient. These are the papers that we came out with. I would like to thank the organizing committee. Finally, this is the area that we need to improve. The consensus statements of the treatment of SMA, people need to be more aware about it, and we need to be aware of the new modalities of treatment for spinal muscular atrophy to expose our patient to these new modalities and ultimately improve the outcome by better selecting the population that receives Spinraza. Thank you very much.
Thank you, Dr. Fahd Al-Suhaib, for a valuable presentation. And thanks for Dr. Wael Bahbah, Dr. Mohammed Zannoun for excellent